Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. You've heard me talk about cycling progesterone. It was the norm in the beginning. The KEEP study, the ELITE study, two major studies that came after the Women's Health Initiative, they included cyclic progesterone. And I've talked a lot about it, and I will talk about it a lot more in the future. But this time, let's talk about the question that comes up a lot. Should you cycle estrogen? So that could mean a lot of things. What is being meant by cycling estrogen? Well, different things to different people. So I have heard that there are some practitioners who have prescribed 2 days off of estrogen a week. Some have prescribed several days off, anywhere from 5 to 7 days off completely of estrogen every month. So, for example, for the weekly, they say on the weekends, like Saturday and Sunday, don't take any estradiol. Or they'll say, don't take any estradiol for 5, 6, 7 days every month. Does that make any sense? Would that help something? No, it's the answer. An absolute flat out no. Let's go back to the famous, wonderful menstrual cycle from which we can learn so much. In a menstrual cycle, there are typically 28 days of a menstrual cycle. Day 1 is the first day of bleeding. So if you have a classic 28-day cycle, and of course there's normal variation, it could be 25, 26, 32, that's the kind of range. But 28 is classic, and that's considered the, epitome of perfection, 28-day cycle. So in a 28-day cycle, you would have 14 days of progesterone and 14 days without progesterone, but with estrogen. And the 14 days with progesterone includes estrogen. Basically, there are no days that have zero estrogen. That doesn't exist. So the amount of estrogen, though, that's produced by the ovaries during the menstrual cycle does vary. But let's just get this out and make sure you know. There are no days of no estradiol. Now, why is it that it would be a bad idea? Maybe it's not natural. There are no days in a normal menstrual cycle when the estradiol level goes to 0 that's coming out of the ovaries. It gets low, but not that low. So, well, there's actually some data that if you suddenly, abruptly stop estradiol, you can actually even potentially trigger a heart attack. It's like too big of a stress to go from having a reasonable amount, hopefully, or some estradiol to suddenly 0, like flat out, you're not giving any. So, of course, there's never totally 0. There's always some being made by peripheral conversion from androgens, mostly coming from the adrenal gland, into estrogens, mostly estrone, predominantly in adipose or fat tissue, but it can be from other organs as well. So the bottom line is it's never totally 0, but it can be pretty darn close to 0. And that is really stressful on the body. You can suddenly have a real drop off in the production of that really critical gas, nitric oxide, that maintains vascular stability. And the autonomic nervous system, which depends on estradiol for the support of the vagus nerve, which has as its main neurotransmitter acetylcholine, which requires estradiol for proper production and function, you will suddenly have dysregulation of the autonomic nervous system, dropping in the production of nitric oxide. This can trigger arrhythmias. This can trigger vasoconstriction. So we don't want to do that. That's why I tell my patients, don't abruptly. If for some reason you need to go off of estradiol, there are a few, not very many. If possible, taper off, even if it's over a very few days. Don't go poof right to 0. So please don't do this. If you're a provider, don't do it. And if you're a patient, don't accept it, okay? Don't go with no estradiol on any days. But so let's put that to rest. But what about changing the level that you give? Well, maybe that does make sense. Oh my gosh, I wish we had more clinical data. We have a little, but not a lot. So if we look at the menstrual cycle, during the menstrual cycle, the first day I mentioned is day one. Day one is the first day of bleeding. Well, at that time, the estradiol level is not zero, but it's low. Okay, it could be definitely in the menopausal range or barely above the menopausal range. Then it rises, though. After like by 2, 3, 4 days, it's rising and it's going up. And then around day 12, you get this giant spike of estradiol, which then triggers a giant spike of luteinizing hormone LH, and that triggers ovulation. Okay, so then after ovulation, rather after the LH spike, it dips. You have a drop in estradiol, a little dip. It goes down quite a bit, and then it comes back up again, and then it plateaus. It comes up higher in the luteal phase than in the follicular phase. When you make the progesterone, there's a little compensation because progesterone downregulates estrogen receptors. So to stop growth of the uterine lining, we don't want to have any more proliferation. We want to have secretory, we want to blossom. We don't want to grow the uterine lining anymore, but we don't want to have problems with growth factors in general. We want to modulate it. We want to make sure that we make plenty of nitric oxide still. We want to just make sure we have enough estradiol so the body makes a little more estradiol in the luteal phase. So typically you can have levels that are in the mid one, if you're talking about measuring picograms per mil, levels that go into the middle 100s, like 150, 170. It could even be in the 200s in the luteal phase for estradiol levels. It can be lower. There's a big range of normals here in fertile women. And in the proliferative phase, or we call the follicular phase, that's the first half of the menstrual cycle. And you're talking about based on the ovary, from the ovary's point of view or the uterine lining point of view. During that phase, when you only have estradiol, no progesterone to speak of being produced, at that time, the estradiol levels are lower and they may go up to more like 80, maybe up to 100 before the big spike of estradiol, which can go into the multi-hundreds. It can go 300s, 400s for that one day. So there's a difference. So maybe it makes sense. Sadly, as we lament and regret that there's so little appropriate research. And I'm trying so hard. I mentioned that before. I'm trying to get funding and start some really good studies to look at all the things that I talk about, because I can only speak from science. I can't help what clinical studies have and haven't been done. I'm trying to get them to happen. But we have to make decisions in the here and now. Making no decision or doing nothing is a decision, which can have big ramifications. So sometimes people want to wait for clinical studies. I respect that. And sometimes people will work based on science and a little bit of hypothesis based on science. So there's rational thinking to say maybe we should vary the dose of estradiol during our pretend cycle. So we would have a different level during the first part, the proliferative phase, and then a different level during the secretory phase. Of course, we can get even more complex and then add in a spike of estradiol. I have done some of this, but it's so hard for patients to do these things. You know, compliance matters. And here's the problem. I know what happens during the menstrual cycle, and we know that when you get that giant spike of estradiol, which then triggers the LH spike, which then triggers ovulation, that it changes how the receptors are working. It also changes how genes are expressed. Nothing has no ramifications. The problem is in actually pragmatically doing this, especially without clinical studies. We know what happens in the menstrual cycle. Of course, we know bad things happen when we lose our hormones, but what we have no clinical data is how and should we try to truly mimic the menstrual cycle. I desperately want clinical studies. I've been begging for this for years, decades even, to have studies so that we know more about how to optimize hormone therapy for menopausal women. But the closer we get, at least hypothetically, to what a normal menstrual cycle looks like, hypothetically, that would seem to be the best. But actually doing that and making it feasible, practical for women to do is another story. So right now, what do I do? What do I recommend? Typically, I try to be sort of in the middle. I try to get a level of estradiol. I know there are many practitioners and many people who are in high level positions in different societies that say measuring estradiol is ridiculous. You shouldn't do it. Well, if you're really trying to optimize healthy longevity, in my opinion, measuring levels matters. If your main goal or your only goal is suppression of night sweats and hot flashes, then there is no point to measuring levels. You will know if you succeeded if the clinical symptoms resolve. But if you're trying to optimize hormones to optimize production of growth factors, mitochondrial health, you're trying to make sure you make enough nitric oxide, you want to reduce oxidative stress. Dose matters. How could it not matter? We know it matters in the menstrual cycle. We know that dose matters in exercise. It matters in how much you eat in terms of vegetables. It matters in terms of the kind of fats you eat. Of course, dose matters. How could dose not matter? I mean, it just seems absurd to say dose doesn't matter. But if you only want to resolve night sweats and hot flashes, then actually dose doesn't matter. What matters is clinical effect. And that is the standard that many, many practitioners, many medical societies hold to, is suppression of symptoms. And of course, we need more studies. We need more data to show what are the optimal levels. I only have the menstrual cycle, which is my guide. That's my guide to the universe. That's my guide to women's health, is what happens in the healthiest women during the healthiest time of their lives with their hormone levels in a menstrual cycle. And what do we know is happening? How the hormone receptors are changing in function, how genes are changing in expression. And we do know that in a normal menstrual cycle, there is a higher production of estradiol in the second half, in the secretory phase, or the luteal phase, or the part of the same time of the cycle, the second half, compared to in the follicular or proliferative phase, the first half. So there was one interesting study, but it was a small number of women that they studied. But in that study, they took women who had no estradiol, and they measured flow-mediated dilation. That's looking at, is the artery constricted or relaxed? And without any estradiol, guess what? The artery was constricted. That would be like getting hypertension, which by the age of 65, 75% of women have clinical hypertension. So without estradiol, vasoconstriction, low flow-mediated dilation. Then they added estradiol. In this particular study, they gave one patch of estradiol, 0.1 milligrams. The levels were about in the 80s picograms per mil, and you had flow-mediated dilation. The artery dilated. Then they added oral 200 milligrams of progesterone. I said oral 200 milligrams of progesterone. They measured flow-mediated dilation. The artery constricted. The flow-mediated dilation went down. Then a different study was done where they gave 2 estradiol patches of 0.1. The levels got up into like the 120s to 140s of picograms per mil. Once again, no estradiol, constriction, low flow-mediated dilation. With the estradiol, dilation, good flow-mediated dilation. But then they gave progesterone 300 milligrams as a gel vaginally, and the flow-mediated dilation stayed good. The artery stayed dilated. But here's the rub. Was it because there was more estradiol? They gave a higher dose with a higher level achieved? Or was it that they gave a higher dose of progesterone, or that they gave the progesterone intravaginally. These are the studies that we need to do to really define what happened. But if we just look at it, the thinking that was going on in that study was explained. They wanted to give levels of estradiol that were more consistent with the secretory phase of the cycle when they added the progesterone. So that's something that I'm thinking about. I'm doing now and again with people who are interested in trying it. I have only the little studies that I just told you. It's not like I'm working totally out in the void with no data to support me or clinical studies. But granted, these are small studies. And it showed that when you gave the patches to get a level like 120s, 140s, and you added progesterone vaginally, you maintained flow-mediated dilation. But when you gave a dose that achieved a smaller level of estradiol, but not really that low, like 60s to 80s, which many women have when they're using these estrogen patches. Some women have lower doses, lower levels from lower doses. Of course, the dose and the level achieved are not always predictable because women absorb differently. And the patches are not, or gels and everything, they're not always exactly the same, even from batch to batch. There's variation, different manufacturers, and so on, a lot of generics. So the bottom line is that in the data we have from clinical study, small, very small, but still using humans, they're not rat studies, they're real clinical studies, that when you had a lower level of estradiol, you had good flow-mediated dilation, but when you added 200 milligrams of progesterone orally, you had loss of that and you had more vasoconstriction. So thinking about that, maybe it does make sense to give a higher dose of estradiol when you add in the progesterone. Or maybe what you need to do is give what I now recommend, give the progesterone vaginally so that you actually have progesterone as opposed to mostly metabolites of progesterone through its first pass through the liver when you take it orally. So these are questions I can't answer. I have hypotheses, I have ideas, but I cannot prove them clinically. So we absolutely need the data from clinical studies. In the meantime, what are we going to do? Well, it's perfectly safe to give estradiol levels that get up into the low 100s, 140, into that range. Of course, it's also safe when you look at the menstrual cycle to have significantly higher. And it's an interesting fact that when you have high levels of estradiol, it actually downregulates its own alpha receptor. So it's like a little bit of a fail-safe that's built in up to a point. Everything's up to a point. So right now, mostly I give the same dose of estradiol throughout the menstrual cycle, and I try to achieve a level since I do believe in measuring levels. I know that everyone does not, but I believe in measuring them, so I know what I'm giving. I think measuring and knowing numbers is actually important if you're trying to be an optimizer, as I am trying, not just suppressing symptoms. And I do know, I always acknowledge we need more studies, we need more data, but I have to live in the here and now with patients who want to have something beyond just a symptom reduction. So I look at the menstrual cycle, I look at the clinical studies that have been done. I think it's reasonable to give the same dose as long as you achieve a reasonable dose, at least over 60, okay? And if you give the progesterone vaginally, then you're not going to have the whatever potential effect from the metabolites, predominantly allopregnanolone. And we do know that progesterone is both synergistic and antagonistic to estradiol. It has its own unique, amazing functions. It downregulates estrogen receptors. That's why we never want to give it every day. But it also is very good vascularly. It does increase nitric oxide. Progesterone does change how a lot of things are working, but it is very anti-inflammatory. It's neuroprotective. It increases the function and health of the myelin sheath around the nerves. It does increase nitric oxide, but it does downregulate estrogen receptors. So it's complex. Let's be honest, we don't have all the answers. But cycling estradiol, maybe it's not totally or even quite ready for prime time, but maybe it's coming. I hope we get studies. I'm desperately trying to get them started and getting them funded because we have to have answers. We deserve answers. We know all the negative things that happen when we lose our vital hormones, when our menstrual cycles cease. And just giving the lowest dose to suppress night sweats and hot flashes from a physiologic point of view seems inadequate. It does do some good, but please don't do static progesterone. We're probably not really quite ready for cyclic estradiol, but that may come. And I'm looking at it. I'm really thinking about it because looking at the data, we know that a normal menstrual cycle is not static with estradiol. Don't ever go to zero. Don't stop the estradiol for any days at all. That does not make sense. And we do know harm from that. We do know that is not good. So stay tuned. I'm really going to try very hard to get these studies going. In the meantime, do cyclic progesterone. Use the progesterone, preferably vaginally. Try to get a reasonable dose of estradiol. Celebrate when you get bleeding. It's a sign that the estradiol and progesterone are actually working. See it for what it is, not as an annoyance. And stay tuned as we learn more and can enlighten everyone about what is optimal for hormone therapy for women in menopause.